Now please welcome back to the stage Bob Cusack and our panelists. Jen Pettis, Director of Strategic Alliances at the Gerontological Society of America. I hope I brought that right. Chad Worz, Executive Director of the American Society of Consultant Pharmacists. Jackie Pinkowitz, the co-founder of the Dementia Action Alliance. And Sue Peschin, President and CEO of the Alliance for Aging Research. Thank you.
Thank you for joining us. I know Sarah just went through the intros, but I want to go down the line. If you could briefly talk about intro you, your group, and a personal connection to Alzheimer's.
Sure. My name is Jen Pettis. I'm the Director of Strategic Alliances at the Gerontological Society of America. Our society is about 5,500 interdisciplinary members, and I think that's really important to mention. We have 26 different disciplines in our membership. And I am a nurse, and so my connection has been over 30 years of advocating for person-centered quality care for people with dementia.
I'm Chad Worz. I'm the Chief Executive for the American Society of Consultant Pharmacists. Our group represents those pharmacies and pharmacists that work with older adults and the medically complex patients in this country. So they service nursing homes, assisted living, they work in primary care settings, really on medication management. I myself am a pharmacist. I have been in this space my entire career and worked in direct patient care, nursing homes, working with people that have Alzheimer's, dementia, and other forms of dementia. So it's near and dear to me. We as pharmacists are always trying to make sure that everybody's on the least amount of necessary medication. So there's two sides to that coin, and we want to make sure people are getting the most from their medications.
I'm Jackie Pinkowitz. I'm one of the co-founders of Dementia Action Alliance. I can't believe it, but it was 27 years ago when we founded it. And we founded the organization because we wanted to have an organization that care partners and people could come to be involved with other kinds of people and other activities so that their lives went far beyond the Alzheimer's experience. Long time.
Hi, everybody. I'm Sue Peschin, and I serve as President and CEO of the Alliance for Aging Research. And the Alliance for Aging Research is the leading national nonprofit that promotes research as a way to enhance aging and health. And we were founded a little over 35 years ago. And we work in both public policy and health education, and I have numerous personal connections, both in my family as well as friends of ours who have had relatives. And we convene and work with all the different Alzheimer's and dementia-related organizations and many patients and family caregivers, people living with Alzheimer's disease and their family caregivers, and I consider them personal friends. So.
Well, Jen, you mentioned you're a registered nurse. I want to talk about educating both patients and their caregivers. How do you do that in a way where you're informing but not scaring?
So I think that it's important early in a diagnosis that folks have the opportunity to engage in education about what they might expect, but I don't think it's that we want to tell everyone everything right off the bat. I think there's certain, agitation's a great example. We want to tell folks that their partner, their person is going to experience some changes in behavior and some psychological changes. But I don't think we want to detail every behavior until it's a little bit later and we really want to help folks to understand what they are. But I also think it's really important to mention that receptivity of the individual and their care partner is going to change over time as well. So we want to offer supports and services, we want to offer education, but the acceptance of that might change over time, likely will change over time. My aunt's a great example. Her lifelong partner has Parkinson's, and I said, let me get you hooked up with the Alzheimer's Association. They can help, they can help. 3 years later, she finally called and said, Jen, can you hook me up with that Alzheimer's Association? I really do need some help. So that receptivity changes over time as needs change and as the person changes.
Have you seen Congresswoman Linda Sanchez was talking about the stigma of Alzheimer's?
Absolutely.
Still out there, right?
Absolutely, and we talk at GSA about brain health. So last time, I always, when I talk about brain health, I say, how many of you have gone to the physician and had them put their stethoscope on to listen to your heart? And everybody raises their hand. And I say, how many of your physicians have talked to you about your brain? And usually, no one. And so patients don't want to talk about it. The doctors don't bring it up very often, so there's this conversation that needs to happen that never happens until it's often too far to engage in disease-modifying treatments, or perhaps there's a crisis, and that's when they engage.
Chad, regarding equitable distribution of treatments for Alzheimer's, how can that improve?
Well, I think we're at an interesting crossroad right now. We have new agents that have come to market that are available that seem to be disease modifying. They're certainly addressing symptoms of Alzheimer's. And when we think of equity, I think we immediately move to racial and cultural equity. But there's also age equity. There's economic equity. Right now in this country, if you're wealthy, you can buy some of these FDA-approved medications because you're concerned. I mean, I don't think there's a member of the audience that if they were diagnosed with early Alzheimer's would not be looking at the agents that we have available and figuring out, how do I afford that or how do I get that? We're not offering that option to everybody. We're creating barriers, whether they're regulatory or through the payers, that limit some people's ability to access some of these medications, and I think that inherently is not equitable.
How do you get rid of those barriers?
I think we have to have honest conversations about, what are the issues that we're having. As a clinician, my job was never to sit there and determine, we have a good drug for you, but I don't think you can afford it. That's not my job. My job is to make sure that you have the most effective medications that you can have to take care of your disease states. We've got to take the other barriers, the economic barriers, the how do we afford it barriers, to a different place and have those conversations and figure out how do we work with industry players and with payers and with Medicare to make sure that people have access to medications. Clinicians need to do their work and treating patients. We need to do the work on the back end at the government level and with the payers to figure out how we afford it.
Jackie, as far as it's so important with any disease, but especially Alzheimer's, to detect it early, how can we better do that? There are a lot of symptoms of Alzheimer's. They're not all foolproof, whether it's agitation or aggression, but they can be symptoms. How can we enhance that?
I don't think I know that it's easier now than it was like 30 years ago when, I was involved with it from my grandfather. And I was horrified to go to his nursing home and see that he was tied up in a bed. I was
He was tied up.
He was tied up. His arms were tied. And this was a gentle little man that never did anything to anybody. I walked out of that building and said, there has to be a better way. And for those of us who have family members, we need to think of better ways. I really did that, and I can't tell you what it did to me to see that visual. And then years later, as my mom developed Alzheimer's, it was so wonderful that my husband Lon and I could find places that they were like little homes, that they could have friendships and they could be out in the backyard and they could feel better as compared to feeling like you're a prisoner.
Sue, speaking of government, you've written about what the president should do. What should government agencies do? We have this big controversy now, and I used to cover CMS when it was called HCFA, so that was a long time ago. But and HCFA stood for something back then, but I can't say it on a family program. But what about the reimbursement? Because now you have the question of both approval as well as payment and private insurers. But obviously, the federal government leads in this area, right?
Right, and that's a great question. It was the Healthcare Financing Administration. I think there's a couple of different issues at play, and affordability, no question, is one of them. But I think that you have to look at affordability in context, and the Centers for Medicare and Medicaid Services, which runs the Medicare program, has really become an agency that is putting financial risk over health risk when it comes to the beneficiaries that they're entrusted to provide care and services for. And that's a problem because folks who are dependent on the program, you know, Chad was talking about sort of like the difference between the haves and the have-nots, people who can self-pay, they are creating coverage barriers under the guise of we need to collect more evidence, when it's really not about evidence, it's more about utilization management, and we're really concerned about those types of barriers.
When you say utilization management, describe what you mean.
Sure, so everybody knows the experience of when you go to the doctor and sometimes they say, oh, we gotta call your insurance company first to see if you can get this drug or this particular procedure done. That's a form of utilization management. Or we have to try you on XYZ before your insurance company allows you on this new thing. And that's what this coverage with evidence development that they've applied to these new Food and Drug Administration disease-modifying therapies really is about. They say that it's about, we're concerned about safety and collecting evidence, but it is really their sort of complex form of utilization management. And it's gonna cut, to Chad's point, folks who live in rural areas, folks who, and we've done, you know, a lot of study on other types of medical products that have been subject to this. And they tend to restrict access to larger academic centers in wealthier urban areas. So that means folks who don't have access to those are shut out and essentially aren't able to get access to the therapies. And that's a problem. That's a problem that Congress needs to pay attention to. They've been doing great work in letting CMS know that they need to open this up. And not only that, but CMS is thinking about this beyond Alzheimer's. This was, you know, sort of a first shot. They were successful at it. It'll be happening more and more for new rare disease therapies, cancer therapies, stem cell therapies, and we're really concerned about that.
As a follow-up, how do we educate people better? The Congresswoman was mentioning, you know, the internet's a great thing, but it's also a scary thing at the same time.
Yeah, I mean, we, in this particular area, for this conversation today, we created these new videos that I'm just so proud of and happy that we did. They're called Expert Conversations, and they feature a clinician and 2 family caregivers and 2 people living with Alzheimer's, just really telling it like it is when it comes to neuropsychiatric symptoms of dementia. So agitation, depression, psychosis, you know, it is really stigmatized, as the Congresswoman said, and people and families feel very isolated. It's one of the top reasons why they need help with, with going to an institution. And I just want to respond to what Jackie said. You know, I think that the people who work in long-term care settings today, they are dealing with more and more complex situations, and God love them. I am so grateful to be working with groups like the consultant pharmacists and long-term care nurses. You are all, thank you for everything that you do.
Jackie, we are going to open up for questions in a few minutes. Let's talk about success stories. You know, you talked about treatment 27, 30 years ago, decades ago. Very different, a lot worse than it is today. How are health systems succeeding in treating symptoms such as aggression and agitation?
One of the big things today is that there are more environments that are home-like and that are more open access for the people who are living there. It's astonishing, the feelings that you feel. I walked into a nursing home and they said, well, you should really go through that door. I said, okay, and walked through the door into a little house. And it was amazing. It was my first experience with it. The people were so engaged, and there was outside, they could go out, they could sit in the sunshine, and they could feel that they were free as compared to being imprisoned, seriously. Very different. So the environment
It's very
is
different. Yep.
very
That's great.
important.
Chad, your perspective on kind of the Alzheimer's treatments that are out there, so much research going on right now, so much advances, but obviously we don't have a cure yet.
We don't have a cure yet, but we're making progress, and there's quite a bit of investment in this age group and in this particular disease state. And if you think about it, and my staff will laugh at me, but there's 57 million people over the age of 65 today. In 2030, which is about little less than 6.5 years, we're going to have 74 million people in that age group. That is a tremendous number, almost 20 million more people that we're going to have to care for as they age. And all of the things that coincide with aging are going to be in a higher and higher frequency. We've got to be able to create solutions, and there is no one perfect solution. I love I have a new friend in Jackie. I love what she says about where we've progressed in terms of creating environments, but the reality is we all want to age in place. We want to stay at home. So if I have products now that treat symptoms, and those symptoms mean as a 50-year-old that with early onset Alzheimer's, if that's me, I can spend more time with my kids. I can slow the progression down of this disease. That buys me something that I can't get if I'm not treated. If I'm a little bit older and I live with my spouse or a friend, not having those agitation moments or those moments where it's difficult to care for me, I can live at home longer. If I'm in a nursing facility that you so aptly described from 30 years ago, where people were being constrained but by both chemicals and physically, if we're able to treat people so that they don't need to do that anymore, then their life, their quality of life is better, not only for them, but for the people that come and visit them and are happy to not see them tied up to a
That's
bed.
right.
So I mean, those things are critical and important as we go forward, and we're just at the tip of what has been a pretty massive investment in this space, and these medications and treatments are coming, and we have to be open and available to them as this population grows.
Jen, as Chad was saying, we're going to need more healthcare workers. I've got 3 kids, they're all interested in healthcare, not journalism at all, and may become nurse. They've considered becoming a nurse. Can you talk about just doctors and nurses right now, post-COVID? I mean, you've obviously talked to so many of them. I've talked to a few of them, and it was just such a stressful thing, and now we're heading into a crush of an aging population that we're going to need. There's some major workforce issues here.
There's workforce issues from numbers that the Congresswoman spoke about earlier, but there's also workforce issues around preparedness of the staff, preparedness of the healthcare worker to learn about older adults. As in nursing school, I took a pediatrics class. Well, I didn't take a geriatrics or a gerontologic nursing class. So people are ill-prepared to even understand Alzheimer's disease, to understand agitation, and to learn about how to document that. I often say, could you draw me a picture of agitation? And folks are, what does that really mean? Well, what does it mean to wander? What does it mean to repeatedly say things? So as nurses and clinicians, we need to understand the behavioral and psychological symptoms of dementia and be able to document them. And then on the flip side, not just document and talk about a reduction in behaviors, but talk about quality of life, talk about engaging in, so when a treatment plan is working, I'm looking at the positive impacts of that care, not just a reduction in symptoms. So I'm really looking at the overall quality of life for that individual, what makes life worth living. And I think we need to learn care planning as person-centered care planning and not disease-centered care planning early in our medical careers, our nursing careers, to really impact overall quality of life for patients as they age across the lifespan.
Got a few minutes left. Let's open up to questions. If you can raise your hand from the audience here at the National Press Club and identify yourself. We have people with mics. You can ask any of these experts anything. Right there.
How you doing? I'm a pharmacist with the Department of Veterans Affairs, and just wanted to ask the question in the sense that yes, it is hard for the government agencies to try to manage the cost and the utilization utilized to purchase these medications that are utilized for these diseases and things?
I do.
Go ahead.
I mean, a couple of different things. Chad referenced the increase in the aging population. And the fact of the matter is we haven't really dealt with that from a fiscal standpoint as a country. Everything has been about how can we kind of control costs, reduce services. And so we need to flip that and take a look at what is required in terms of investment. You know, we all pay, everybody here in this room and listening today, we pay into these programs. We pay our taxes. And it shouldn't be that you get a particular condition and that's the one that we point at and say we need to control costs there. And that's what we're doing right now. So we need to sort of look at how are we investing in the system, and you know, and we need to take a real look at other aspects of healthcare costs too. You know, there's this sort of laser focus on drugs, and there's no question that's valuable. We've participated in those debates very closely because they impact who we represent. But there's a lot of other aspects of healthcare as well that we need to pay attention to.
What's your name?
My name is Ivan Cephas.
Ivan, thank you for being a pharmacist and thank you for what you do. I would just reiterate, you know, again, and I kind of come back to one of the things I said before, as clinicians, whether you're a pharmacist, a nurse, a physician, we want to be problem solvers. We want to take care of the people that are in front of us that have problems. We want to understand them as people. We want to make sure that they're getting the right things. Oftentimes, the structures and the payers limit our ability to take that action. And all I can say is we've got to keep fighting for that person that is in front of us and fighting for what they need. My father is a veteran. He goes to the VA. I tend to believe that the VA is one of the most impressive healthcare systems that we have, but it is driven to some degree by cost, and there are lots of conversations around whether or not we should do this because it's costly, and not enough conversations around we need to do this because it's the right thing for this person. So hopefully we can keep having those conversations and pushing that ball forward.
We have run out of time. I want to thank our panelists, and I also want to introduce our next speaker. It's our caregiver testimonial. Carrie Shaw is the CEO and founder of Embodied Labs and a caregiver for her mother. Please thank our panelists and welcome Carrie Shaw.